Good evening, everyone. So, we'll start the class right now. Many of the aspirants will be joining us soon, though. Today's topic is endocrine disorders, and the speaker that we have here is Dr. Avishek Roy, who is an associate consultant ICU in Apollo Multispeciality Hospital, Kolkata. Hello, sir. So, you can share your PPT and start the class. Thank you.
I'll be starting today's discussion. So today's class is on endocrinology, and I'll be covering it over the span of next say 2 to 3 classes. So today's topic is based on sugar control in ICU, broadly based on the sugar control, the level of how we manage sugar in ICU, and along with that, the management of diabetic emergencies. So I'll start right off. So, so first coming to the thing that what is dysglycemia that we face in critical care, that we face a lot of variations in our blood sugar levels. The pathogenesis underlying is multifactorial, so it could be because of the underlying stress, the disease process, the sepsis, multifactorial causes. So it causes of wide fluctuations of blood sugar levels. So the dysglycemia in critical care itself is associated with worse outcomes. Next is we'll discuss about the use of HbA1c and then the evidence supporting the whatever we are telling. What are the glucose monitoring in ICU? Management of diabetic emergencies, namely hypoglycemia, DKA, and HHS, and some question answers. So coming to the first thing first, what is the current definition of diabetes? So it's if it is single HbA1c value of more than 6.5%, the test should be performed in a laboratory using a method that is standardized and National Glycohemoglobin Standardization Program. Fasting plasma sugars should be more than 126, that is the fasting levels. And fasting is defined as no food for at least 8 hours. And after a 2-hour meal, that is a 75 grams of oral glucose tolerance test. That's a standardized thing. So if the sugars are more than 200, then we call it diabetic. And if the patient at a very random sugar levels more than 200 with sign symptoms of hyperglycemia, we can mark them as diabetes. So that's the latest definition we should all be aware about. Now, coming to hyperglycemia and hypoglycemia, so any blood sugar level more than 200 is clinically significant because this is associated with increased risk of infections. It is also causes mitochondrial dysfunction by creating lots of reactive oxygen species. It increases the ICU length of stay. It is also associated with increased ICU acquired weakness. So that's why our glucose control in a reasonable range is important. It reduces the neutrophil elastase activity and the neutrophil chemotaxis, and along with that also reduces the phagocytic action of different different cells like macrophage as well, leading to the increased risk of infections. So similarly, when you have hypoglycemia, when your blood sugar levels less than 55 generally, so that's it can be the definition of hypoglycemia varies in adults. If it is generally is marked as less than 54, some book says 55 milligram per deciliters without symptoms, or less than 70 with symptoms. So this is the current definition of hypoglycemia. However, in the ICU, the patients are often obtunded. They have multifactorial reasons for getting admitted. They might be having sepsis. They might be intubated. So they might be having encephalopathy. So the assessment of a patient's sensorium or signs of per se hypoglycemia is very much difficult. So in that case, less than 70 is taken as a universal definition of hypoglycemia. Why hypoglycemia is dangerous? Because it can cause neural damage. It increases the heart rate. It causes a sympathetic stimulation, causing increased perspiration, increased blood pressure, and also in the prolonged stage, it can cause seizures. When seizures occur, it mostly indicates some form of neural damage, which call it neuroglycopenic manifestations. So, in terms of an ICU patient, hypoglycemia is generally more damaging as compared to hyperglycemia because of the neurological manifestations. Other than the hypo and hyperglycemia, the variation of sugars during the ICU stay, which is measured by something known as COV, coefficient of variance. Supposedly on day 1, the patient has a sugar level of 88, and on day 2, you find sugars of 300. So it's not that neither 80 is hypoglycemia nor 300 is very high sugars, but this huge variation in the sugar levels causes a damage of the internal milieu of our body in terms of fighting the bacterial infections as well as the overall osmolarity of our system, and also damages the kind of overall electrolyte fluid balance. So the glycemic variability itself is associated with
Silence.
and the other thing that is important is TITR, time in the target range. So supposedly we want to keep a particular set of target for our sugar control, say 140 to 180 or 140 to 200. Now, if you keep the numerator is how many amount of times that you have checked the sugars and the sugars were between the level divided by how many times it was actually checked. This percentage is called as the TITR. So it should be in the range of somewhere between 65 to 70%. I've not mentioned this in this slide, but it should be between 65 to 70%. So 70% of the times, your blood sugar level should be bang on between the target levels. If you're away from that, your patient is going to get hurt. So these are all the variations of sugar management that we have to take into account. What is stress hyperglycemia? Many a times patients who are non-diabetic gets admitted to ICU. On day 1, patient sugars are through the roof, probably 200, 300s. And the patient relative says he's never been hyperglycemic in his life. So in that case, what happens is because of the acute stressful reaction, because of the sepsis, because of the steroid hormones and the ADH, along with the different cortisols and growth hormones, and the disbalance between insulin and the other gluconergic hormones, there is increased amounts of blood sugar since. But this is not diabetes. Diabetes is defined as when you have some form of beta cell dysfunction of the pancreas. So to differentiate between the two, we can use an HbA1c. Whenever a diabetic patient gets admitted, always send at baseline HbA1c. HbA1c is an average marker of the glycemic control over the last 3 months. So it does not depend on your recent sugar levels. If your sugar levels have been controlled over the last 3 months, it will be normal. If it be high, if it is uncontrolled, it will be low if it is associated with hypoglycemia. So a normal HbA1c but raised blood sugar indicates the patient is having a stress hyperglycemia. A not elevated HbA1c, high sugars, the patient is non-diabetic. Along with there is a degree of something called as dysglycemia. So whenever a patient in ICU is undergoing some high sugar levels, use the term dysglycemia as compared to other terms like hyperglycemia or diabetes. So HbA1c guided sugar levels can help us to guide what could be the target sugar levels for this patient. So there is this formula that is ADAG, HbA1c derived average glucose. So this formula you don't have to mug up, just for the sake of information I put there. So if you put this, substitute this, you'll get an idea that this should be the target sugar level in this patient. If your sugar levels are below that or above that, that means that is either a relative hypoglycemia or a relative hyperglycemia or the stress hyperglycemia, that which I just spoke about. So this glycemia and admission divided upon the mean glycemia, which is derived from the HbA1c, this gives us the stress hyperglycemia ratio, which is again a marker of sugar control in our ICU. And the current sugar minus the expected sugar as per the HbA1c is known as the glycemic cap. So again, I'll just revise it quickly. So there are few terminologies which might be new to a few of the the aspirants. Other than hypo and hyperglycemia definition, we have to know the glycemic variability, which is the overall change of sugar levels, the time in the target range, the amount of the time sugars are within target over the denominator, that is the number of times it has been checked, usually should be 70%. Stress hyperglycemia is hyperglycemia noted first time in the ICU without a background of diabetes. Usually it is differentiated from a diabetic patient by virtue of HbA1c. And there are terms like ADAG, SHR, and glycemic gap, which are also important, which are parameters of sugar control. Coming to the insulin therapy, what are the types of insulin therapy? So insulin therapy, I have mentioned it a bit in later on the slides also. So as I was speaking, so I'll discuss on insulin therapy in the coming slides. Now this is the pathophysiology of a stress hyperglycemia. Whenever a patient is undergoing stress, any patient in ICU, even if admitted for very minute to minute reasons, they undergo extreme amounts of physical stress. So that leads to the release of corticotrophic releasing hormone from the hypothalamus, and that stimulates the pituitary, and subsequently pituitary secretes ACTH, and from there on the adrenal gland secretes the cortisol. And then again, the pituitary and other organ systems, they secrete lot of pro-inflammatory molecules like interleukin 1, interleukin 6, which are also the cause of raised sugar levels because it's secondary to cortisol levels. The end of the epinephrine and the norepinephrine, which is normally secreted under stress response, they're also glycemic. They increase the blood sugar levels because of increased glycogenolysis. So the combination of all the factors like cortisol, epinephrine, norepinephrine getting increased, along with a relative insulin resistance that is seen in these cases, all these things culminate in a higher sugar levels. Now, how does the HbA1c kind of help us in management in our patients? Other than the fact that it gives us an idea that this is the target sugar levels in this patient, if a patient's HbA1c is, say, normal, say somewhere between 6.5 to 8, it means the patient had a tight sugar control, and we can go ahead with a tight sugar control in the ICU also. Tight doesn't mean that it should be very low. It means that we have to keep it between 140 to 180 or 140 to 200. We should not allow the sugar levels to go beyond 200. However, if the patient's HbA1c levels was more than 7%, or uncontrolled sugar, say 9% or 10%, you can keep the patient's sugar levels a bit higher, and that would be less damaging as compared to a tighter control. So, meaning if a diabetic patient with HbA1c of 9 having a sugar level of say 220, probably I'll not give insulin to the patient. I just let it be because that's the usual sugar levels that the patient is accustomed to. So HbA1c helps us in determining the amount, the strategy that we're going to follow, whether it's going to be a more stringent strategy versus a strategy known as permissive glycemia. So permissive glycemia concept I'll be telling afterwards. Now coming to the next part of our discussion is what should be our target sugars when we manage a patient in ICU. So ICU, there is a lot of variation as to the. I'll just complete the previous part once, that the type of insulin and all those type of insulin I'll be discussing a bit later. So insulin is usually given subcutaneously, but we can give intravenous. And why we prefer intravenous in a patient who has a very high sugar levels is because in critically ill patients who are on ventilator, on multiple vasopressor infusion, the peripheral perfusion is poor, so subcutaneous absorption is kind of dismal. So in this case, it is preferable to give an IV infusion. And usually when you give an IV infusion, you monitor more frequently. Usually that's somewhere between 1 to 4 hour interval. Again, the discussion will be coming afterwards. Now, what should be the target sugar levels? Now, for the sake of exams, we have to know one or three or four names of major trials that paved our path in terms of the determining the target sugar levels. The initial trials were in the year of 2000s, early 2000s, where there was this Leuven surgical trial. It's a place in Belgium where Vanderburg et al. Did a trial on around about 1600 patients who were requiring mechanical ventilation, and they divided patients in two groups. One having a tighter sugar control, that is 80 to 110, and one having a liberal sugar control, 180 to 200. And what they showed is that the mortality and the risk of infection was significantly high in the patients with liberal group, means patients with in whom the sugar levels were kept higher, they had bad outcomes. So this raised eyebrows for many intensivists, and then came the date. There was a time when they started really rigorously keeping sugar levels to a lower limit. But there were many drawbacks to this trial. One is that it was a pure surgical trial. So patients who are post-surgical unit, it was done. And if you go through the methodology, you will find that multiple loopholes. Many patients were given IV dextrose, some patients were given oral along with some TPN. So there was a huge variety of variability in terms of the methodology, not kind of a standardized trial that you will want to quote while targeting your or depend or deciding upon your sugar control. Next came a medical ICU trial on the same center on 1200 odd patients, which target, and the comparison was also same, 80 to 100 versus 180 to 200. But there they found that there was no difference in primary and secondary outcomes. And intensive insulin therapy, IIT Stanford intensive insulin therapy associated with increased incidence of serious hypoglycemia. However, the in-hospital mortality was better with intensive insulin therapy despite having higher incidence of hypoglycemia, and they favored that they favored they gave a verdict in favor of intensive insulin therapy. This led to a lot of confusion. Now intensivists were running around the hospitals with insulin syringe and charts, running behind the nursing staff to have a tighter sugar control. That brought forth two major trials. One is YSIP, which was a 2:2 factorial trial, where they actually compared the use of starch versus crystalloids and intensive versus a liberal kind of sugar management strategy. And they found out that in those patients, between the two strategies, there was no significant difference in terms of mortality, and there was higher incidence of hypoglycemia, severe hypoglycemia, and seizures in intensive insulin therapy. Now, this is the first trial which showed a path that the whatever the previous trial showed probably isn't that much true. And then came the biggest trial regarding this topic. I want everyone to know at least one trial. If one trial is asked about sugar management strategy in ICU, what is the quoted trial? That's a nice sugar trial. It took over 6,000 patients that were included in the trial. It was a multicentric trial. So previous trials, most of them were unicentric. When you take patients from all over ICUs, you are actually doing a pragmatic trial. You are considering different variation of practices as well. And the primary outcome, they took a 90-day mortality, which is also a very good outcome measure, and they showed that the intensive therapy group had increased chance of mortality and increased deaths of cardiovascular cause and there was obviously more cost involved because you're measuring more frequently sugars more frequently, the risk of hypoglycemia etc is more frequently, and there was no huge difference in terms of any of the effect. And they said that the sugar control should not be that much tight, it should be liberal, somewhere between 140 to 180, and that kind of eased the life of our current intensivist as well. So this is the landmark trial which has to be quoted, the best trial till date on this topic. Now, after that, there are another two trial came, the glue control call, which also showed in around 1,000 patients. That was an RCT which showed that the intensive insulin therapy associated with more chance of hypoglycemia. It was stopped early because of the futility of the trial itself. And surprisingly, the Vanderburg, who first devised these trials, the Leuven surgical and the MICU trial, they came up with an updated trial on their own with 9,000 patients in their 2023, published in INDIGEM, and they found out that an intensive versus liberal, so they did not compare between an intensive 80 to 110 versus standard, that's 140 to 200. They compared intensive versus liberal, that is more than 215, is using some logic insulin algorithm, which is basically some AI based algorithm, and they compared length of stay, ventilator free days, everything were same. But in this trial, surprisingly, despite this tighter sugar control, the incidence of hypoglycemia is only 0.7% or less than 1% in these patients, which is surprisingly low. The cause, after analysis, people could only say that probably the nursing staff were more agile, more workaholic. But to keep a patient sugar between 80 to 110 consecutively, you will risk the patient having more risk of hypoglycemia. So the trial demonstrates that the equal safety of both the strategy. And now comes a newer concept that argues the modest permissive hyperglycemia. That's probably a sugar level till 250 is safer, and as compared to normoglycemia. And the intensive insulin therapy, the tighter sugar control is now out of the book. So to summarize, our current recommendation is to keep a sugar levels between 140 to 200 or 140 to 180. Both are acceptable. Even there are trials which are saying that a less tighter control till say up till 240 or 250, especially in diabetic patient, is acceptable. Don't beat your head out if your sugar levels are 240. It's not going against the management. However, if your sugar levels are below 140, especially below 100, somewhere between 80 to 100, and you think that no, patient is not having hypoglycemia, this patient is bound to get hypoglycemia when you're not monitoring. And you are monitoring at least hourly interval. There will be episodes in between an hour where the patient will have hypoglycemia. Therefore, do not follow the intensive insulin therapy. Target 140 to 200 for the time being, and less liberal strategy or a bit more liberal strategy is more welcome. What are the methods of glucose monitoring? Generally, we go by the capillary blood sugar method, but as usual in every ICU patients, there is risk of sorry less perfusion because of vasopressor requirement. Patient may have significant edema. So all these things leads to significant amount of error, and the amount of error can rise up till as much as 30 to 40%. So your sugar levels might be 40, but the actual sugar levels might be somewhere between the 60 to 70, which makes a huge difference. And that's why checking the blood sugar levels or checking by the arterial or the venous blood sampling is always preferable. Between a VBG and ABG, there is not much of a difference. You can check either the VBG or the ABG. What I mean by ABG and VBG is not particularly blood gas analysis. You can take a sample from the arterial line and check in the glucometer. That is also acceptable. If you have a proper co-oximeter in your ICU, which analyzes the ABG, the co-oximeter levels are much more accurate as compared to blood sugar, which is shown on the glucometer. So, if your patient is having a blood glucometer levels of 90 and your ABG, which is normally calibrated showing a blood sugar of 65, it is the ABG which is more accurate and not the capillary blood sugar. Do not cross check your values in the ABG with the capillary blood sugar. There is a phenomenon known as leukocyte larceny. If you have increased amounts of leukocytes in your blood, for example, hyperleukocytosis from acute myelocytic leukemia, myeloblastic leukemia, or hyperviscosity syndrome from other causes, you might have a falsely low blood sugar levels because all the leukocytes they end up eating or taking the glucose. So in those cases, there are some precautions to be taken. I'm not going into the details, but this is one phenomenon you need to be worried about. And the other method that has come up is continuous glucose monitoring. So rather than pricking the patient or checking repeatedly and bothering the nursing staff, there are sensors, glucose sensors, subcutaneous glucose sensors, which take sample from it based on microdialysis principle, which take sample at the interval of 15 to 20 minutes, and any fluid can be used, for calibration purpose. Generally, it is safe. It is used, although it is called continuous. It's a misnomer. It checks at the interval of 15 minutes, as I said, but nonetheless, it is much more less labor intensive and more frequent as compared to what normally we practice. Drugs like paracetamol, dopamine, and mannitol they interfere with the readings of this technique. So not much in VO. I don't think CGM can be asked in a question, but just to remember what are the techniques, CGM or continuous glucose monitoring is a newcomer technique. And there is closed loop monitoring, AI based thing, where you have a particular sugar level. Based on that, you have an algorithm put forward, and then the insulin is automatically adjusted or reduced based on the sugar levels.